TV. TV.
11?
Yeah.
11 in the morning?
Yeah.
11 in the morning. Okay, so he's understanding what I'm asking him, but he has a non-fluent output of speech, sometimes just single utterances, but he's trying to communicate the correct content. He knows the question. They want him and his wife as a computational psychiatry duo. Her as a spousal hire, and then a separate couple from the search for cognitive. Princess Hoffman said she didn't feel impeded by antithetical requirements for computational scientists. So you can't make this shit up. Right? Just what you remember. I'm telling you, it's my life. This is hard. So I'll go to the meeting, and I will make one comment. I talked to Danny Kahn, and he said you need to hire Peter Dyer. That's my comment. So you're not ready today? No. Okay. Sorry. Yeah, well, I'll try to get it there because I don't I don't want to do it on the last day because I want to have a little mini review of the course, what I think are high points, of the different sections. Huh?
I won't be here.
At the high point?
I'll be there.
Yeah. No, but so we'll see. I think I can get done by this and this connection because they're really connected. No, I'll get 20 minutes. It'll work out. Don't worry about it. Whoa. How we doing back there, world? Good? Good? Awake? Good? Can you hear? Yes? There? Good? I want answers. I want to assume it's good. All right. Okay, good. All right, so we're in the home stretch. We have 3 classes left, and we're going to do a lot on language and cerebral lateralization in the next 2 talks. And then the last lecture will be on perceptual visual agnosias, but I think I'll probably keep about 15 or 20 minutes of the last lecture, and I'm going to kind of go over what I think were the important things, just highlight some of the things that I think are important that I'd like you to take away from this course. Just my quick summary of the course. Okay, so we stopped with this beautiful anatomical lateralization in the human brain, with the left superior temporal plane being bigger than the right. And then we basically, I thought I got these lights out of here. What do we do? Room controls. That's better. Okay. So we started to talk about big fiber pathways connecting language areas. And this is really important in the sense I don't want you to go away from this course as phrenologists. I really want you to be thinking that, yes, they're important hubs that have assigned more importance in a task than other areas, but you don't work in isolation. Things are rapidly moving information around in the human brain at breakneck speed. As I said, you can get an impulse from the front of the brain to the visual cortex in about 13 milliseconds. Right? So you can imagine you've got a lot of data you can move around. So we talked about the uncinate fasciculus in neurobiology of emotion, the orbital frontal amygdala connection. Now we're going to talk about the arcuate fasciculus, this beautiful large bundle that connects temporal lobe structures involved in language perception, as we'll talk about today, with inferior frontal structures involved in the production and selection of the words that will actually be articulated. And this is just an extremely beautiful wet dissection where someone took painstakingly isolated this. And this is, of course, with your imaging that you learned about in vivo with the fusion tensor imaging. Now, the password, this is not a slide for you to remember. This is a slide for you to just remember things there's a lot of pathways and highways in the brain moving information around. And more keep getting delineated. This classic one, the uncinate fasciculus, the big superior longitudinal fasciculus with Wernicke's area and Broca's area, large pathways in the hemisphere between frontal and parietal structures that are related to allocation of attention. We talked about this asymmetry with a right hemisphere bias, and lesions in this pathway can produce that really very interesting syndrome of hemispatial neglect. And this is a really interesting paper I just became aware of, so I put it back I put it in the talk, and I think it's a really nice reconstruction by this particular person. And basically, he took where the injury was, engaged, it was a rod going through his orbital frontal cortex. In patient Tana Broca, it was a lesion in the inferior frontal cortex. And in Henry Mollasan, it was actually bilateral resection of his hippocampus, leading to profound anterograde amnesia, inability to learn new information. And he just said what fiber pathways would be affected. It's really quite beautiful. Phineas Gage has lots of intrahemispheric fiber connectivity with different areas of the frontal lobe, the lateral frontal, the cingulate. They're all impacted by that rod going through his frontal lobe, in addition to getting the big connection, the uncinate fasciculus with the amygdala. If you go to Broca's case, patient Tan, you actually see an entirely different set of pathways being engaged and knocked out in this, including a large part of the arcuate fasciculus and other pathways connecting language areas, not only in Broca's area and Wernicke's area, but other areas in the frontal lobe and other areas in the parietal lobe that are all engaged in language. And then in the famous Milner case, patient HM, again, and I can put his name here because he's deceased. He appeared in big newspaper articles. They discussed his life, etc. You can see the output of the hippocampus, some deep pathways in the fornix going down to the mammillary body is affected. Fibers going through the anterior commissure, connecting this little green thing, connects the two anterior temporal lobes, and then this big cingulate bundle, a completely different highway dysfunction in these three classic neurological disorders. So back to language per se, and this is actually a review slide published in 1914, and it basically by Desjardins, a very famous neuropsychologist, and he wanted to just point out that we knew already about three important things in language in humans. And he was reviewing the work by Broca on Broca's aphasia, and he reviewed the work on Wernicke's aphasia in the posterior temporal lobe, and some of his own work on where lesions in the angular gyrus produced very selective deficits in reading and writing, alexia and agraphia. So, what else do we know about these language areas? Well, from the neurosurgical perspective, when you're trying to do neurosurgery, you want to preserve language cortex, of course, and you want to preserve motor cortex. And the way to really do that is to precisely know where it's organized in you versus you versus you. Everybody has a slightly different distribution. And you want to make sure you've got it mapped out so when you put that scalpel or that cauterizing iron into the brain, you're not hitting language or motor cortex. So this is work from 1952 from the great Wilder Penfield, the Canadian neurosurgeon. Patients were getting prepared for surgery, and they're talking out loud. Maybe they're counting 1, 2, 3, 4. And whenever they stimulated these dots, 1, 2, 3, 4, patient stopped talking. Okay? This is work from my colleague at Mitch Berger, who has a very big brain tumor program. And this is just a few of his cases, again, showing the exact same distribution in the exact same task. So nothing's really changed. And Mitch does this, and all our epilepsy doctors who are trying to really get a fine tune on language do this mapping intraoperatively. So Broca's region, we have it right here. It's sitting right here, area 44 and 45. The pars triangularis and the pars opercularis sitting right there in the inferior frontal lobe. Here's your motor strip. This is about where your hand area is. That's why a lot of these patients, when they have an infarct, not only have trouble speaking, they usually have a right hand weakness, simply because the motor area is really, the motor cortex, the motor homunculus is very nearby. So here's a patient that I might have shown you this early in the course briefly. This is a classic patient with Broca's aphasia. He can follow commands, but you're going to see he has anomia. He can't name objects. And he has a very severely constricted output in speech. He has telegraphic speech. He's only saying 1 or 2 words per sentence instead of the normal word length, which is 8 or 9. The patients drop the size of their sentence, and the first thing they drop are little connecting words. So if they were going to say, I am going to go to the store, a Broca's patient might say, I go store. They've kept the most salient but dropped out these little connecting words. And more severe, it might be I go, but even in worse cases, they may have trouble with any amount of articulation. So let's just take a look at this gentleman. Let's check your language out now. Can you tell me what happened when you had the stroke?
Ja, sitting best, ja, sorry.
Do you remember, was it in the morning or the afternoon?
TV, TV.
11?
Yeah.
11 in the morning?
Yeah.
11 in the morning. Okay, so he's understanding what I'm asking him, but he has a non-fluent output of speech, sometimes just single utterances, but he's trying to communicate the correct content. He knows the question. He's
right
telling me it's 11
He's
a.m.
not moving his right hand.
Can you tell me, where were you born?
63, 68.
Phonemic paraphysic
63, 66.
60.
I see, okay. Where were you born? What city?
Wingland.
Where?
Wonderland. Linwood.
Linwood?
No, Wonderland.
Let's
The
just try some
neologistic
simple language
paraphrase.
things. What's this called?
He had a phonemic. He said 3
To
for
be.
3.
A what?
To be is to be.
A to-be. It's kind of a phonemic error for toothbrush. He certainly knows what it is.
Classically anomic.
So he is anomic. What's this called?
Key.
Excellent. What's this called?
Key.
Perseverated.
Key.
Stuck on set now.
Key.
What do you do with it?
Key.
Okay. Is it a nail?
No.
Is it a hammer?
No.
Is it a screw?
Yeah.
He actually knows what it is, but he was stuck on set. He kept saying it's a key, thinking it's a key. Yeah.
When you asked him where he was born, he answered when. Is that right?
No, when did it? When did it? If you actually listen, it's just a weird. The numbers thing is interesting. This is a good observation because you say, well, it's language, right? So the aerial writing of the information should be also impaired, right? Writing goes with verbal output. But you do see these interesting asymmetries in the ability to write versus the ability to talk. His writing is still very impaired, but it is true that he tried to communicate with a symbol, which is communication. So I think the main thing to remember, these things are not absolutely clean, but this is a Broca's aphasia patient with paraphasic errors, speech constriction, and anomia. We can all agree on that. Okay, so these are Broca's first 2 cases. So the question is Broca's area really the key to you being when you're, is it really involved when you're speaking to someone? This is patient Tan, Broca's first case. And he was called patient Tan because he just repetitively said tan, tan, tan. You probably heard about this 100 times in your psychology classes. This is his actual brain. And here's his infarction. And they never cut his brain. It's still sitting in preservative in Paris. And we'll get to that in a minute. This is another one of his cases here. And this case had a similar severe language output problem with only single word output, just like patient Tan. But if you look closely, there's only a very small infarction in the pars opercularis. There's not a big, huge infarction taking out all these areas. That's a problem for the theory, which has been going on for 160 or whatever years, that Broca's area is actually engaged as you speak, right? Because there's a lot of Broca's area left here. So what's exactly going on that explains this discrepancy between these 2 patients? So Nina Dronkers, who actually just moved her lab to Berkeley, she's got for those of you interested in language, she has a very big aphasia program. She's actually moved up into the 2nd floor Barker. She's a very large aphasia cohort. This is Nina, and this is what's called a very happy neurolinguist. And the reason she's a very happy neurolinguist is they let her open up the jar Broca's brain was in. That's her holding Broca's brain. There's Broca's infarct. And basically what she did is she floated it in an MRI scanner and did an MRI scan of Broca's brain. And lo and behold, it turns out that certainly Broca's area was lesioned. We can see that. But there's extensive underlying damage in the anterior insula. And you can't see it here. The arcuate fasciculus are taken out. And if you look at, this is a summary. I'm her neurologist for her aphasia program, which is a lot of aphasic patients. This is a summary of 36 patients with chronic Broca's aphasia, where we overlap their lesion to see what is the site common to all these patients who have Broca's aphasia. And lo and behold, it's actually not Broca's area. It's actually the deep infarction involving the anterior insula and the arcuate fasciculus. So this really challenged the entire notion of what was going on. And I should mention, if you just get this lesion alone, with no undercutting, no deep lesion in the anterior insula of the fasciculus, the patient does have a language problem, but only for about a week or 10 days. They're mute. They have trouble speaking, and then their language returns. Right? So I'm not going to go into it in this class, but Adine Flinker, who's now at NYU, did a very elegant study using direct brain recording in epilepsy patients and showed quite conclusively that Broca's area is actually involved in language, but it comes on before you speak. It's kind of a motor area, kind of putting together the sequences to drive the articulators to produce the speech. It's not really directly involved when you begin to speak. It shuts off. So all this comes together, and you have to revise your idea, really, of this classic notion. And it does show you how bringing more modern techniques to the game, including just simple MRI scanning showing this pattern of infarction in the seminal case, and direct brain recording changes our view of how your actually brain is organized for language. So the idea is this. This is the more typical lesion. You can see the insula is infarcted. This is a contrast-enhancing scan. If it came up higher, there'd be frontal involvement. And this is a very typical infarction where not only Broca's area is taken out, but the arcuate fasciculus is gone. Now, I would just want to mention what another aspect, a novel aspect of speech that we see very commonly in these Broca's aphasia patients is apraxia of speech. Now, we're going to talk about this at the end of today, but I just want to let you define to you again. We mentioned it earlier in the course. Apraxia means your motor strength is intact, right? Your actual lower motor control is there, but you can't sequence the movements to produce the right kind of behavior. You're off on putting your movements together, right? And this is extremely common in Broca's aphasia, at least a third of cases, maybe more. The way that I check for it is I have them do a very simple task. Open your mouth, stick out your tongue, and pucker your lips. First, I show that they can do each individual thing correctly, right? They can open their mouth, okay, they can pucker their lips, they can stick out their tongue, but they can't sequence it. They have a problem with putting together a series of motor acts. They're apractic. And that particular lesion localizes quite nicely to the anterior insula, anterior insular cortex. Here would be a scan of a case kind of laid out, and you can see the insular infarction there. And it's this area right here. And Nina published a really nice paper showing that this was again, confirming that part of the problem with the patient articulating and talking to you was also damage in the anterior insula related to the sequencing of motor acts. Very interesting observation. So what about Wernicke's regions? That's Broca's area. Output. Now, I don't want you to believe that their comprehension is perfect in Broca's patients. The more complicated you make things, they may make a few errors. But in general, you can converse with them. You can do the three-part commands that I told you about earlier in the course. I put three things in my hand. I say to the patient, pick up the keys, put the coin on the floor, and you pick up the pencil. The Broca's patient can do that. The Wernicke's patient can't. Now, for Wernicke's aphasia, again, we're now talking about the cardinal left hemisphere language right-handed person. So we're going to talk a little bit about the left hemisphere, but this can be extended to the right depending on the hand of this, etc. This is Wernicke's area. It's in the posterior part of the temporal lobe. It involves the superior temporal sulcus, the superior temporal gyrus, the planum temporale, the superior temporal gyrus, and the superior temporal sulcus. And lesions centered in this area produce the following kind of problems. Well, before I show you the patient, again, back to Mitch Berger. When you're doing the intra-op mapping, first we want to know where your output area is. The next thing you want to know is can we get a little bit on your comprehension area? And it's done very simply in the operating room. And it's simply presenting on a computer screen in the operating room images of, let's say, a banana or an apple or a cat or a door or whatever. And the patient, each time the thing comes on, they simply name. They say cat or door or whatever. These are sites in the back part of the brain. Remember, these are the sites which disruptive stimulation, produce the speech arrest. These are sites in the back of the brain, again, in this critical posterior temporal lobe, that produce anomia. The patient can see it, they know what it is, but they can't name it, just like this gentleman with the Broca's aphasia, as you noticed, couldn't name. He knew what the toothbrush was, he couldn't find the name. Okay? So that's the intraoperative component of this. So here's a patient with a really severe Wernicke's aphasia acutely. He had an intracerebral hemorrhage from a medication side effect. But what you will see here, first thing, his automatic speech is actually intact. I can't remember what I say to him, but he immediately says, okay, I'm fine, right? And it's just pointing out the automatic speech. If you just go in and do an aphasia exam, you say to this gentleman, you say, how are you? And the patient goes, fine. They can be completely aphasic because they can be doing that simple phrase with their non-dominant right hemisphere. So you have to be careful. So let's look at this gentleman. He speaks a lot, makes no sense. He has profuse paraphasic errors. The individual sentences have no linguistic structure. So he has deficits in the lexical access. He has deficits in semantic. And he can't, I'm not going to show you the comprehension part of the exam. Just trust me, he can't follow any commands. How are you feeling today, sir?
Pretty good, yeah, actually.
Automatic speech.
Not a pet where I'm going, but I'm matching there, and then I got things moving on vegetables, vegetables, but I'm really not actually, not really
Profusely
handling. I'm just
logistic
out there,
paraphrases.
man.
Are you having any headache? Did your head hurt you at all?
Yeah, I guess what you are on your S. It's not on my S in sense, but it's whatever S was Dan that I've not approved. Even this stuff is almost fair bass and my bass was tan.
I see. He is unable to understand anything. He's talking a blue streak. It doesn't make any sense because his complete language structure is basically affected. The other thing about him, for those of you going into anything clinical, when I ask him questions, he talks to me like he thinks I'm understanding him. And there's no way I can understand anything. And and I know he's aphasic, of course, and that's normal. But you have to be careful because sometimes when people keep talking and talk through you, it can be a symptom of mania, right? It's called pressive speech. They just keep talking and talking. But mania does not have linguistic destruction of the lexicon and the semantic axis. The sentences might make no sense. They may have blends of paranoia in them, similarly in any psychotic break. So it's really quite different. Schizophrenics, people in any psychotic break, the sentence is intact. The way the sentences are put together get lost. You become tangential. You may throw in paranoid features, etc. Yes? Yes, that's the point I'm trying to make, but you asked the question better than I was trying to explain it. So let me just say this. The Broca's patients are totally aware. They often have a catastrophic reaction. That's what it's called in the literature. They're acutely very sad and tearful that they can't communicate. They know they have a problem, right? And you have to be aware of that because they're at also higher risk for long-term structural related depression. So if I see someone a couple of weeks or a month out from a Broca's aphasia or frontal infarct and they're still, when you lose something, you get depressed, right? You have a loss in the family, right? And you feel sad. That goes away. May come back occasionally, but it goes away. It's when you have a chronic depression, you have to think about treatment. And that's, if I have someone who's showing depressive signs 2, 3, 4 weeks down the line, I will treat them. They will go on a conventional antidepressant drug. The Wernicke's patients know. That's the point I was trying to make. He's acting like I understand what he's saying, and I don't understand anything he's saying. Yeah.
Does he have some kind of tremor or
Yeah, he was on anticonvulsants. He was taken off barbiturate and another anticonvulsant, and he was a little jittery, basically. Okay, and this is what it looks like acutely. It's a contrast-enhancing infarction in the temporal lobe, part of your middle cerebral artery. This is an old MRI scan of one of my patients. You can see right where the lesion is, and this is what it looks like at postmortem. And these patients often have no motor deficit, no cerebral, they may not even have a sensory deficit. So you have to be very careful because the milder cases, this guy's pretty easy, but some of the less severe Wernicke's, you still could make a mistake and think, oh, this person's psychotic. So be careful. They're not. The language structure is impaired in patients with aphasia. So in summary, Here's Nina's study. This is Wernicke's patients, chronic Wernicke's patients are less, you don't see as many. They often evolve into just a persistent anomia. But we do get some who are severely, persistently Wernicke's for many, many years. And this is over the rough same time span. I showed you 36 chronic Broca's, but here's only 13 chronic Wernicke's. Here's the lesion overlap. You can see it's beautifully right there, sitting in the temporal lobe, right smack in the junction of the superior temporal gyrus and superior temporal sulcus, etc. Another patient, this is what the infarction would look like. Broca's area is completely spared. Motor areas are spared. This is some additional work from my lab, and I'm not going to go into the details, but again, we find that you get word meaning when you look at it electrophysiologically with direct recording from the cortex of patients who are being evaluated for epilepsy. The key spot across patients is actually in the same exact area physiologically that matches with the lesion and with the chronic lesion. So the story comes together quite nicely. Now, aphasia obviously is not a good thing to have happen, and there's speech therapy does work. It does improve people. So there's things that can be done to try to get back a lot of your language. You'll get a lot more back with a posterior lesion. As I pointed out to you, we have more patients with persistent Broca's type symptoms, but they can improve also. And the Broca's patients are really not at such a disadvantage because they understand what people are saying to them. It's when you don't understand what people are saying to you that you got a real problem, right? Then you're really cut off from any form of effective communication. So the most catastrophic aphasia that you can get is called, pretty aptly, global aphasia. What's a global aphasia? Well, if you go back to our vascular stuff and you wonder, why is he going over this stuff? Well, here's the anterior cerebral artery, getting your medial frontal lobe and your cingulate. Here's your posterior cerebral, getting your hippocampus and getting your visual cortex, which we'll discuss a little bit at the end of the course. Here's your big old middle cerebral. And we talked about this if it's infarcted on the right side. I got the patient is now looking at us. You get hemispatial neglect. On the left side, you can get frontal eye field or temporal parietal junction, contributions to getting, you can get frontal eye field and temporal parietal contributions to neglect. Same thing on the right side, Broca's area, Wernicke's area, but if you include the trunk, the origin of the middle cerebral, so the blood supply to the back of the brain, Wernicke's area, and the blood supply to the front of the brain is compromised, you take out the entire middle cerebral distribution. This is a global aphasia. This is really bad because, A, the patient doesn't understand what anybody's saying to them. That's a problem. And again, it's not just your auditory communication. It's also written. It's language. They have problems understanding language. They also can't speak. So they are effectively, and because the lesions are big, you can see this is a chronic lesion. It's taking out that artery on a CT scan. Because they're big, they also get motor strips. So they're getting hand area. So they're invariably hemiparetic. So here you have a patient who can't understand anything that's being said to them, can't communicate anything, and is paralyzed on the right side. That's not good because oftentimes you end up in chronic care facilities, and then as soon as you're in chronic care facilities, even the good ones have an increased incidence of things, venous occlusions, infections, etc. So the lifespan is really markedly decreased when you have a global aphasia. I just wanted to mention a couple other rare aphasias, and I mention them because they get misdiagnosed. And I know some of you may actually be doing this for a living someday. So there's a syndrome that I've seen 8 cases of. That's over a lot of years. It's called epileptic aphasia. And I'll just tell you the example of one of them. This is a young lady who was 33 years old, who had been admitted to the Highland Hospital psychiatry unit 3 times for psychosis. Her Wernicke's aphasia was misinterpreted as schizophrenic word salad. Okay? That's number 1. You're not going to do that. She then had a grand mal seizure on the psych ward. Thank God, because they got a neuroconsult. And her EEG basically showed spiking in her left hemisphere, in her left temporal lobe, in her Wernicke's area. So what she was really having was epileptic aphasia. She had a very small cortical malformation. This is her bedside writing. You can see it's completely screwed up with paragraphic, juck for muck or whatever, all these kind of, some curse words thrown in, etc., completely disorganized. The bottom line, the reason she had a seizure is they gave her an antipsychotic that lowers seizure threshold. So her focal seizure in Wernicke's area actually generalized, which was good for her. And then she got put on anticonvulsants, and that's it. That's the end of the story, basically. So keep that in mind. We've already talked about this. This is not the acute syndrome in the psychiatric ward or whatever. And by the way, people who've had aphasia, who've recovered, who have a scar left, a cortical infarction, they can also get epileptic aphasia. So they come back into the hospital and you think, oh, they're having another TIA. Maybe not. Maybe they're actually having a seizure. So you need to get an EEG in these patients. Yes? You can collect your $20 at the end of the class because I think that's the next slide. I'm not sure because my sequencing may be off a little bit, and I was playing around with these slides. We talked about early in the course the tauopathies, the various forms of frontotemporal dementia. One of them actually presents with word-finding difficulty and progressive problems with semantic access, so-called semantic dementia. And here's an example. Here's a relatively intact right temporal lobe patient, again, is looking at you, and here's a very severely atrophied left temporal lobe. But the patients initially don't present with a lot of atrophy. They actually present with anomia, with a relatively normal MRI scan, and your index has to be up, that this is the beginning of a tauopathy, one of the subtypes of frontotemporal dementia. Oh, look at that. It was actually, got it right. Good. All right. So, I've seen two of these patients. They're not very common. And there used to be the school for the hearing impaired used to be in Berkeley, actually. It's been moved, but we saw a couple cases at Highland Hospital early on in my career. And this is a really nice lady. I think I've got one thing out of sequence here. This is a nice lady who, at age, I think 6 months, had a meningitis and went deaf at 6 months from the meningitis. And she was very fluent in sign language. And she sustained this infarction here. And this is my best reconstruction. It's an old CT scan. This case was 1981 or 1980. And that was the lesion that I reconstructed, with a lesion right here, just slightly above what you might call Wernicke's area, but right in that multimodal cortex there. That was the subcortical extent. Up until this point in the literature said that sign language was a right hemisphere function because it's visual and you're putting objects in space, etc. But if you actually looked at the 100 years of these reports, every single case that I could find in the literature actually had right-sided weakness. That doesn't really fit with a stroke in the right hemisphere. So this case was really, I think, a very important case because we clearly showed that the left hemisphere, and particularly areas in the posterior part of the left hemisphere, were critical. We had a sign language person come in. I didn't know how to evaluate sign language, but she was making inappropriate locations of her signs, and she was also not able to decode signs. So she had a Wernicke's aphasia for sign language. Again, emphasizing the point that language is communication through use of symbols. Does that get at your, okay? We had a very similar case to this. And this is her, just to show you, this is her post, a pre-stroke. She was writing a letter to the DMV, a very intelligent, very pleasant lady. I'm enclosing several pieces of identification, blah, 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 blah. You can read it. I'm a deaf person, have great difficulty cashing checks. I don't have an ID. It's perfect language. Let's just say that. This is at her bedside after I saw her and she had a stroke. You can see she's got these sentences that make no sense. Cow have mother, tree, something, money, sleep the boy morning, fair, hair. She's making paragraphic things like phonemic errors in speech, hair for fair, etc. although I'm not even sure what she's trying to communicate there. So really quite classic. It was an interesting case. I remember her quite clearly because I saw the case about 4 days before my daughter was due, and I told the residents, let's just take care of the lady. Let's not tell the world we have a rare case of sign language aphasia, please, because I got a baby coming. Let's just cool it. The next morning I came into the hospital, and Ursula Bellugi, who's one of the top sign language people in the world, has already flown up from the Salk Institute and is in the patient's room testing the patient. So I wasn't able to put the kibosh on that, but in any event, and it was published eventually in Brain. It is an important case, though, both for understanding sign language organization and emphasizing the communicative aspects of aphasia. All right, so let's see how you're doing here. Who wants to diagnose the first case? Somebody. Okay. Yes? Was that a yes? Did you move your arm? No? Yes. Anybody? Okay, I got to get more specific. This is going to be interesting. Who's pre-med here? No one's pre-med? Okay, you're on up there. You ready? You go. I'm going to show you two cases. I want you to tell me if it's a Broca's aphasia or it's a Wernicke's aphasia. Okay? Actually, you just do the first one, and then we'll get somebody else. So all the people who are going to come for letters who want to go to med school. God, there's many more that seem to have raised their hand. This is interesting. Here we go.
Oh, yes. Way over the 2 weeks, Livermore.
You're going to go there?
No. Last, Hungary. Hey, that's what I like. Max is...
Did you drive over there?
No, but...
That's what you were thinking about when you...
Yeah. Hey, garage there by mother nuts.
Okay, what is it? Yeah, why? You're correct. Correct. Yes. Non-fluent. Okay. Good. Next case. Who's the other? Where are the other pre-meds? There got to be more. Okay, you ready? Oh, you want to do it in tandem, the two of you? You want to call a friend who wants? You ready? You both can do it. You can communicate somehow telepathically. All right, so let me see if I can do this without screwing up. I think we'll skip him, just so you don't think it's just an order of different types of diseases. Can you pick up the quarter?
Can they pick up?
Can you pick up the quarter?
Sure, I can.
Please do.
The corner.
Thank you. You put it down. Okay. What I want you to do now, if you could, is put the key on the bed and then pick up the screw.
This is the ski in the cane?
Okay, that is the key.
Yeah.
What I'd like you to do is put the key on the bed. Put the key on the bed.
Pin the cane on the poo? On this?
No. Can you tell me a story? It's the boy breaking the
What's
glass.
broken? The glass and grass.
Okay.
Glass.
The glass is broken. The window is broken. Good.
Window glass.
Who broke the window?
Who broke it?
Who broke it?
Well, let's say it was maybe the kid hiding, but he did.
You think the kid hiding broke it?
Yeah, I mean, he was hiding, he did it.
Mm-hmm. And who is he blaming?
Who's ghosted?
Who is he blaming?
He is, the man is.
Okay.
We ran to the window. I mean, door.
Ran to the door.
Yeah.
Okay, what do we got? The first one he did. He could follow a one-part command. How would you describe his speech? What kind of errors was he making? Yeah. He can't follow a two-part command. So by definition, if he can't follow a two-part command, does he have a comprehension deficit? Yes or no? How many commands do I do when I do my neurological exam? Pick up the pen, put the keys on the floor, and you pick and put the pencil on the bed. That's a three-part command. Everybody should be able to do that. How many could he do? A one, a two, or a three-part command? He could only do one. So by definition, he has a severe comprehension deficit, unlike a Broca's patient, which means by exclusion he's a Wernicke's patient. He's not as severe as the first one, who could really understand nothing. But then you see his speech. Sometimes he'd put a 5 or 6 word sentence out that kind of was not hard to understand or had phonemic errors in it. Yeah, okay, good. So you're ready. Ready for the emergency room. It's like the surgeon, right? See one, do one, teach one. That's why there's, when you have your appendix out, it's probably being done right by a resident, more likely than not, doctor, up there. Yeah, he agrees. Okay, real quickly, the role of the right hemisphere in language. What's spared? You saw the first gentleman, automatic speech was spared. I don't have an example in here. Maybe I'll grab one and show you next time. The patient with a severe Broca's aphasia can sing. So if you get him in cadence and you start singing happy birthday, they'll sing, which means your right hemisphere can sing, even though the patient can't say the words happy birthday to you. They could sing happy birthday. Kind of amazing. They can make simple semantics. They can understand simple sentences. What's impaired? Their prosity's gone, which we've discussed before. In other words, they have a flattened affect with right hemisphere. They just have a neutral output, and they also can't decode if you're happy or you're angry. And I can't decode the prosodic elements of your speech. They have problems getting the gist of a joke, which is quite common. That's actually associated the most with right frontal lesions, where humor appreciation, the lateral right frontal, is affected. There's a very beautiful paper by a colleague of mine, Don Stuss, some years ago, on humor appreciation and brain lesions, published in Brain. They're not completely normal in terms of putting together a narrative in the story. In everyday conversational speech, you wouldn't notice it, but if you force them to give them prompts to tell me a story about this, usually their narrative is not going to be as rich as it should be. So it's not like they're completely normal with right hemisphere damage. This is even in a strong right-handed patient with very strong language lateralization to the left side. There's still some involvement in language processing in the right hemisphere. Okay. So let's do limb apraxia real quickly. This is an ability to do sequencing of movements. It's really pretty easy to think about. There's idiomotor, which means I tell you to do something and you can't do it, but you can do it spontaneously. And then there's the severe form where you have such a breakdown in your motor control that you can't do any elementary movements. And I'll just show you. This is idiomotor apraxia. The patient can do spontaneous movements, so they can feed themselves, etc. But the movements break down when you tell them to do something. There's a disconnection between the verbal system and getting the motor system to behave. There are often body part substitutions, and I'll show you what that is. It means you ask them, for instance, to show me how you brush your teeth. And a normal person would do this. I do this. They'll do a body part substitution, and they'll do this. Right? And I'll show you a couple movies of that. Ideational apraxia, which we have a very poor localization on, the cases are rare, is a severe breakdown in motor planning and control. And that's typically associated with bilateral damage in the parietal regions of the brain. Idiomotor apraxia is almost in every case a left hemisphere syndrome. So you see it quite commonly with aphasia. It runs with aphasia. And this is the idea. There's a left hemisphere network. We published extensively on this. Kathy Holland at University of New Mexico has been the lead author on looking at all kinds of neural organization of apraxia. In a nutshell, almost all the patients have lesions in this frontal parietal network. Higher than the language network, but still in the left hemisphere. So I'll just show you two quick movies. Here's an idiomotor apraxia patient or two, and you're going to see they have the classic body part substitutions. Simple movement,
Okay,
he can't
good.
do it.
Watch me again.
He's close, but he can't do it. He's got normal strength.
Okay.
He can move his hand. He's almost there.
Okay. Watch me again.
Okay. I don't know.
Idiomotor apraxia.
All right.
Can't do it to verbal command. He can't get the act together.
Well, I know, but I can't say it like that.
Okay.
He's paralyzed in his right hand, by the
Can
way.
you try to do it at all? Okay.
Got that one. Almost pretty good.
Good.
There's a whole battery you give the patients. They don't have to be off on everything. Can't quite do it. Can't
Okay,
quite
good.
do this. Is tapping. That's an abnormality.
Okay, good.
Almost. So I think you get the idea. As opposed to
Okay,
now, in
wait till I'm
everyday
done.
life, they could do this. They could
It's
do every
okay.
single thing. They can't do it when they're guided to do it by verbal command. Brush your teeth. Okay, he just did a classic body part substitution, right? Instead of holding the toothbrush,
good.
he used his finger as the toothbrush. All right, so that's enough of that. And then finally, the most severe breakdown in motor control. You can't do anything. This unfortunate gentleman with bilateral posterior lesions can't even open and pour a can of Coke. He has such profound motor deficits.
Wait a minute, now, you know, you're doing it. I have this board well. Yeah, go ahead.
You can imagine how frustrating this is.
I haven't opened the tonic at all, yeah. Signs I know last week. Really? Turn the can around a little bit. Try it again.
And his dexterity and strength is intact. He can't organize the sequence of motor tasks. So you can see that this apraxia runs with aphasia. And what we'll do, we'll pick up on Monday is disconnection syndromes, how your two hemispheres exchange information and communicate rapidly.
Roger, turn the can. Turn the...
Sure. Depression, you see typically, particularly. Yeah, that's very common. No, you treat the depression independently of the stuff you would do to try to improve, motor function and rehab. Completely separate, in parallel. I didn't say separate, but in parallel.